Howdy, everybody. Aaron Boster here, and thank you for learning about MS with me. It is MS Awareness Month, and I've made a commitment to jump online and live stream often during this month of March to help us raise the level of awareness, to help energize, to help educate, and help empower people impacted by MS. And so here we are again. I plan on, let me adjust the camera here. That's looking okay. I plan on live streaming for maybe an hour right now, and I'm hopeful that you guys are willing to jump online and have a conversation with me. I am really enjoying this forum as a way of connecting with you. It makes me feel awesome to read your comments and to get a chance to share and learn from you and to share some of the experiences that I've had in caring for people with MS for almost a decade and a half. Now, as always, as you jump online, please share with me where you're jumping on from. I love this online global community. And if you have a chance to tell me where you're coming from, I would love to hear that. There are 54 of us who have jumped online. That's awesome. If you love this format and you want to see more live streams this month, make sure to give a thumbs up below so that I know that you're into what we're doing here. Now, I've got people from New Jersey. I've got Jen. I've got Candy Duncan online again. I've got Claire Dick saying hello. I've got Darla. Hello, Darla. I've got Vicky. Howdy, Vicky. This is fantastic. And I wanted to talk today about a couple different things. One of the things I wanted to talk about is my channel. This is a living, breathing phenomenon, and I'm doing it for you guys. I'm doing it to bring MS education. I'm doing it to help empower. I'm doing it to help energize you. And I want to make sure that you're getting out of it what you want. And so a couple things. I've recently grown large enough that I qualified for monetization. Now, I don't want to make money off YouTube. That's not really my goal. But I was very excited about doing a super chat. And so I recently clicked the button to apply for monetization, and I got it. And now I don't think I like it. And so I want to hear from you guys. Include down in the comments, what do you think? And I want to present a couple different options. One option is I just turn the monetization off. And that's relatively easy. And that's kind of what I was thinking of doing. The other option is that I keep the monetization on. And I use the proceeds for one of the foundation funds where I work at Ohio Health to help educate our employees. We have an educational fund that we use to send social workers and nurses and nurse practitioners and trainees to national meetings. And so my other thought was maybe I would use the proceeds to fund that. And so please do me a favor and leave a comment down below, whether it's on the live stream right now or whether you're watching this on the replay. And let me know your thoughts. I really care about that. Do I, A, turn off the monetization? Because I'm not really looking to try to make money off of YouTube. Or do I, B, maintain the monetization, which means you guys are going to be subjected to advertisements. And I will use that money to go into one of my foundation funds at Ohio Health MS Center to help bring education to our employees, to help educate nurses and social workers and physical therapists and the like. So let me know what you think. I've got Sandra from Columbus, and I've got Patty Strickling from Florida. I've got Andrea saying hello, howdy, hi. Beth Smith is on saying educate. I love that. Born again farm girl. I think that you're very helpful. So monetize, doctor. All right, well, that's cool. I've got Vicky saying foundation funds. Now I'm going to go through and carefully read this later, but please leave a comment and let me know, are you in favor of maintaining the monetization, which means you're going to be subjected to advertisements, which I don't know how you feel about, and I'll use that money in a foundation fund. And it'll be, if I do that, it could be kind of exciting to be able to come back to you and say, guys, the money that we've collected is being used to send a social worker to the CMSE or whatever the case may be. But the other option, and the one that I was kind of leaning towards, was to turn it off. So we don't monetize at all. All right, enough said. I am looking forward to your comments. I'm going to take seriously what you tell me because I've created this for a forum for you. And I'm very curious to see what you guys come up with. I'm looking through some of the chats right now. And Karen writes in, get paid and use it to help educate. All right, well, this is really cool. Hey, guys, this is neat. If you'll notice in the comments, Charles Boster is online, and that's my dad. He's with Karen. And so the fact that the two of them, my stepmother and my father, are online is absolutely amazing. Dad, I love you. Karen, I love you. Thank you very, very much for jumping online. That's really freaking cool. My father has been a mentor and a staple in my life. He has been a guiding voice for me, and I owe him a tremendous debt of thanks. So I'm going to say it live on this live stream. Dad, I love you. Thank you very, very much for being here. It means a lot to me. Let's jump into some questions. I would love to answer your questions live. Now, you guys know the rules. I can't diagnose you on the interwebs. I can't treat you on the internet. I can't read something you write and then I can give you an answer and medical advice. What I can do is I can answer general questions to raise the level of awareness and to educate. So please frame your questions as a general question so that we can all learn. Let's see here. So Paul writes in, and Paul says, "Hi, Dr. Boster. What factors go into your recommendations for Ocrevus over Lemtrada or vice versa for a particular patient, since they're both effective? Thanks, Paul from Illinois." Paul, I love that question. And it's a question that I'm asked often. And so let's unpack the question and let me jump into its answer. So Lemtrada, which is codenamed for alemtuzumab, and Ocrevus, which is codenamed for ocrelizumab, are two of the most effective MS medicines that currently exist. They are both infused medicines taken through the vein, and they're both highly, highly effective, as Paul points out. Now, I have many videos on my channel. In fact, I have an entire playlist about Ocrevus. I have an entire playlist about Lemtrada. And so if you guys have specific thoughts or questions about the way the drugs work or about the monitoring or about my opinions, then you can most certainly go onto my playlist and check that out. But Paul's question is a great one. And he says, how do you decide if someone should go on Ocrevus or someone should go on Lemtrada? And the common answer, which is not the one I'm going to give you, the common answer is something about risk factors and side effects and looking at the severity of the person's disease. And I do not think that's how you make the decision. I feel very strongly that there's a very simple answer to help you figure out one way or the other. Now, before I give you that simple answer, full disclosure, we've treated a bunch of people with Lemtrada. I'm talking over 260 souls at Ohio Health MS Center have gone through the rigor of Lemtrada. I really, really like the drug. I think it's one of the most effective drugs out there. We also have used a lot of Ocrevus. There are over 850 people that we've treated with Ocrevus. So I have not a small amount of experience with these drugs. I would argue that I have a large breadth of experience. I'll also share with you that I was involved in the clinical trials for both drugs. And so these aren't drugs that are relatively new to me. All right. So how, with that background, how do I sit in a room with someone and help them decide, are we doing Lemtrada or are we doing Ocrevus? And here's my answer. My answer is a philosophical answer. I think philosophically, there is a stark distinction between the person that wants to embrace Lemtrada and the person that wants to embrace Ocrevus. And I think that they are very, very different. So let me explain what I mean. Lemtrada is induction therapy. Lemtrada is a medicine you take for 5 days, then you wait a year, then you take for 3 days. And then you don't continue to take it unless you have new disease activity. Going out 8 years, we know that people with MS from the clinical trials, 55% have never been retreated. 55% got that first 5 days, waited a year, 3 days, and then they went 8 years and they never got retreated. Only 30% of people needed a third course, and 12% of people needed a fourth course. So the vast majority of people that take Lemtrada don't get retreated. Now, when you've made it out 8 years and you haven't been treated and you haven't had an attack or new spots on your MRI, that's pretty darn special. Taking Lemtrada, however, is very, very complicated. It's not a take the drug and move on kind of therapy. In order to be safe with Lemtrada, you have to do a lot of stuff. So you have to have examinations of the neck. You have to have skin examinations. If you have a cervix, you need to have a pap smear. And then you need to have a battery of blood tests looking for all kinds of opportunistic infections in kidney functions and liver functions and thyroid function. And then after you start on the drug, you have to take a cyclovir. In my clinic, we give people a cyclovir for almost 2 years straight. And also, you have to have monthly blood draws and urine samples every month for 4 years after your last dose, which is a minimum of 5 years. So my point is, there's a lot to be done to handle Lemtrada. In counterpoint, in some ways, Ocrevus is a bit different. Now, Ocrevus, which is also a highly effective therapy, is a therapy that's given through the vein every 6 months. So it's one infusion that you get, and then 6 months later, you get another infusion, then 6 months later, you get another infusion. And Ocrevus is a continuous therapy. You're going to continue to take it until you die of old age, or until the drug fails you, or until there's another reason that you switch to something else. Ocrevus, unlike Lemtrada, doesn't require a lot of monitoring. And so prior to starting Ocrevus, we like to make sure that you haven't been exposed to hepatitis. So we check hepatitis panels for hepatitis B. And at my center, we like to make sure that we have a TB test done. And after that, there really isn't a lot of monitoring. Now, we do recommend standard screening for breast cancer. And I've talked a lot in videos about why. But my point here is, you're taking Ocrevus, you're coming into the infusion center every 6 months, and then you go out and live life and you come back every 6 months. So here's the philosophical point. There are some people who are willing to accept a lot of upfront risk and complexity in exchange for a chance of not having to do anything and having quiet disease in the absence of having to be on a therapy. There are other people that do not want to do that. They do not want to subject themselves to the complexity and the risks up front, and they are willing instead to take a continuous therapy forever. And those people are different. Philosophically, as I talk to folks, some people are willing to put up with induction therapy at a chance of having quiet disease without being treated, whereas other people are not willing to do that, and they are willing to take a continuous therapy for a long time. So, Paul, thank you for your question. I am saying hello, howdy, hi in Illinois. I hope that you're staying warm there, and I hope that answers your question. That was a really good one. All right, so let me look down and see where the next question is. Guys, if you have a better way for me to sort through the questions, let me know. It's challenging for me to try to look at the camera and then look down and read. And I feel bad for you that you have to sit there and stare at my bald head when I'm trying to find the next question. So I apologize for that. But let me find the next question that we're going to look at. All right. Here we go. I found it. Sorry about all that, guys. So April writes, glad your family is on here. Doctors give so much of their time, and their family has to give up time with them to do it. So share with us. Thank them. And I am. Dad, I love you. Thank you very much. Karen, I love you. Thank you very much. I know that my mother, Carol, jumps on sometimes and comments on my videos. I know that my wife will sometimes do that. And I have friends that do the same thing, and that means the world to me. They are my intimate village, and they're super important to me. All right. So let's see what the next question is. So a lot of people are writing in about the ads, and I thank you for that. I need to hear from you guys what you think about monetization. I turned it on, and I'm not sure I should have. And so there's a lot of people writing in about that. I'm going to look through that in the post. I'm going to read through that, and I'm probably going to tally it up, and then I'll do a video sharing with you the results. So looking for MS questions here. Here's one from Ron, who writes, "Hey, Dr. Boster." Hey, Ron. Can you have an organ can you get organ transplants under Lemtrada? And so that's a pretty cool question. Ron asks, if you've had Lemtrada, can you have an organ transplant? And the answer is, it depends on the timing. So Lemtrada is biologically active in your body for only about a month, and then it's out of your body. And it's actually safe to become pregnant. Oh, the question was removed. 4 months after you have your infusion. And so from a exposure to drug standpoint, Lemtrada is out of your body pretty darn quickly. Now, the effects of Lemtrada, of knocking down your adult B and T cells, take much longer to return. It can take a year or more before those cell lines come back. During that year, I would certainly not want to subject someone to a transplant. After that year, it would be okay. So in my opinion, after you've had Lemtrada, after your cell lines normalize, which is probably going to be a year or maybe a little bit longer than a year after your second dose, you would be eligible for a transplant. So that's a great question, and I hope that helped. Cindy writes in, is it possible to have an exacerbation while on Ocrevus? And can you still take steroids to stop an attack? Well, hello, Cindy. Thank you for the question. The answer is yes, you can have an attack on Ocrevus. Now, when we studied Ocrevus in the Opera trials, and these are relapsing MS patients, we compared Ocrevus against Rebif, which is a standard of care therapy that I don't like very much and I don't use very much. The people with MS that took Rebif in this clinical trial, the Opera trial, had attacks. The annualized relapse rate was 0.3, which is a math way of saying they would have an attack on average once every 3 years. So that was the frequency of their attacks statistically. If they took Ocra, they cut that in half. And so we're talking more like an attack every 5.5 to every 6 years. But my point here is it didn't stop all attacks from occurring. People could still have attacks. And anecdotally, having used Ocrevus post-marketing after the launch of the drug for about 2 years now, with a lot of people, some people have an attack. So yes, you can have an attack on Ocrevus. I would tell you that it doesn't happen very often, which is awesome, but it can happen. Now, the second part of the question is, can you take steroids despite being on Ocrevus? And the answer is yes, you absolutely can take steroids. When you receive Ocrevus, we give you a tiny dose of steroids, about 100 milligrams or 125 milligrams of IV prednisone prior to the infusion. That's done to make the infusion more tolerable. But if you require high dose steroids, we're talking about 1,000 milligrams IV of IV Solumedrol done for 5 days in a row for a serious attack, yes, you can do that. And yes, it is safe. That was a good question. All right, let's look at the next one. So Marcella writes in, are there more concerns for round 2 of Lemtrada as opposed to the first? So she's asking about the sequencing of the Lemtrada. And as you guys remember, the way Lemtrada is given is weird. You have 5 consecutive days of infusions, and that's the first round or the first course. And then a year later, you have 3 consecutive days of infusions. That's called round 2. And she's asking if round 2 is more concerning than round 1. And the answer is no. When we study this, and we have studied this, each subsequent round of Lemtrada is tolerated better. And so in groups, people tolerate the second round better than the first round. For people that needed a third round, they tend to tolerate it better than the second round. And so there still is concerns during the infusion. You can have serious hypertension during the infusion. And if that's not monitored carefully, there can be bad things that happen, like brain bleeds even. That's very serious, but it's controllable by controlling blood pressure. So that means that we have to do a good job of infusion medicine. There can be rash. There can be, in fact, 97% of people have infusion reactions during the clinical trials. And so there's a lot of attention that needs to be given. And let me make this point. I don't think that you should give Lemtrada casually. I think that you want to get Lemtrada somewhere where they give it a lot. Now, my father, who's online, required hand surgery. My father is a woodworker extraordinaire, and he uses his hands quite a bit. And so a woodworker having hand surgery is a really big deal. And we found an orthopedic surgeon who only works on hands. He doesn't do elbows. He doesn't do shoulders. He doesn't do hips. The dude only works on hands. And that's the right guy for my dad. If your dad needs Lemtrada, I would recommend having Lemtrada done at a center where they do a lot of it. Now, it doesn't have to be at my center. It could be at some other center. But the point is that we have a tremendous experience giving Lemtrada. I think that we're really good at it, and our nurses do it a lot. And so that gives them a sense of confidence, and they know tricks and tips on how to make it palatable and tolerable and safe. And that's what I want for you. But the direct answer to your question is no, it's not worse. It's typically better the second round as compared to the first. All right. So April writes, they are thinking about changing the 6-month period between Ocrevus infusions around for weeks. My brain needs it. And again, and feel active. All right. So I think what I'm reading is, what about the frequency of dosing? And so right now, the way that the label is written for Ocrevus is that you give one infusion every 6 months. And the reason is that it takes about 6 months for the B cells to come back. Remember, what Ocrevus is doing is it's killing all the B cells. And it takes about 6 months to grow back the adult B cells. I shouldn't say all the B cells because that's not true. It doesn't kill the stem cells. It doesn't kill the plasma cells, just the adult B cells. And it takes 6 months for those adult B cells to grow back. And so that's why we give it every 6 months. Now, if there was some concern about a return of disease activity, there's a really cool test that you can order, a blood test, which looks at something called the CD19 count. So if you check a CD19 count, you can find out if the B cells have returned earlier. And so let's say that you have someone and you gave them Ocrevus. In month 4, they feel horrible and they're concerned they're not doing well. And there's a concern on the table that their B cells have returned too early. Well, you can check that. You can draw, it's called immunophenotyping. That's a lot of words, immunophenotyping, and it gives you a CD19 count. And if the CD19 count is 0, you know that the B cells aren't back yet. And if the CD19 count is above 0, you know they have returned. And if they have returned, that might give you some indication that they've come back too quickly, and it might lead you off-label to consider treating sooner. That's food for thought. It's a bit theoretical, but it is something that you can do. Great question. All right. So, gosh, I'm not going to pronounce this name very well. Mehmet Kursan, and I'm sorry if I pronounced your name wrong. So they asked the question, hi, Dr. B, what is the side effects of Tecfidera for long-term usage? That's a great question. Tecfidera is an MS medicine. It's a pill. Pills are kind of nice. They're certainly better than shots. And Tecfidera is a pill that you take twice a day. So Tecfidera has a couple side effects that are generally mild to moderate. People can have GI upset. They can have diarrhea. They can have upset stomach. And oftentimes, if they have that, it can go away after a couple weeks or a couple months. And it seems to be better when people take food. So that's one thing that you can see with Tecfidera. Another thing that you can see with Tecfidera is that people can have facial flushing, like going through the change of life and your face gets bright red. There's a medicine called niacin that can make your face flush, and Tecfidera can make your face flush. Now, most people don't have it. And if you do have it, the timing matters. And so we find that people have flushing, particularly if they don't take food before they take the medicine. So taking the medicine on an empty stomach is an increased risk of having facial flushing. And if they change the timing of the dose, even by an hour, some patients notice that their face flushes. So those are some side effects, but they're normally not that big of a deal. Now, when you're taking Tecfidera, it's important to check liver enzymes. Rarely it can make your liver enzymes go up, and so you want to check liver enzymes, and we do that every 3 to 6 months, because if the liver enzymes go up, we can stop the medicine, and then they go back down. There's one other important thing, and this gets to your question about long-term concerns. Tecfidera is not supposed to drop your white blood cell count. That is not the way the Tecfidera is supposed to work. Tecfidera is supposed to work by stimulating this thing called the NRF2 pathway, which tricks the cells into thinking they're under oxidative stress. And then the cell responds with an antioxidant cascade of loveliness, which ends up quieting MS. But it's not supposed to work to decrease the white count. There's a side effect that may be seen in upwards of 20% of patients where their white count goes down, and specifically the lymphocyte count. So lymphocytes are one of the white blood cells. When you say white blood cells, there's actually 5 flavors, and one of them are the lymphocytes. And there are situations where the lymphocyte count drops, but it's not supposed to. And if it drops below, say, 0.8, that makes me uncomfortable. It makes me uncomfortable in that we have seen rare infections. Rare, I mean, it's not happening very often at all, but it can happen. Rare infections, including PML with Tecfidera, and they occurred in patients who had a low lymphocyte count. So if you're on Tecfidera, you want to make sure that you manage the facial flushing and you want to manage the GI stuff. That's typically upfront and transient and tends to go away. You want to make sure that you're getting your liver enzymes checked. And if you're one of the people that has a dropped lymphocyte count, I think that's a reason to come off the medicine. Now, that's my opinion. But I don't want to subject you to undue risk. And so thank you for asking that question. All right. So Vicky says, my MSPA met you in Germany and thought you were great. Well, that's really cool. Thanks. She's referring to the ECTRIMS meeting. So this was in Berlin, Germany this past year, and it was a really amazing conference. I did some videos while I was there where I interviewed some of my friends just to talk to them about what they thought of ECTRIMS. ECTRIMS to me is the Olympics of multiple sclerosis. I started going to ECTRIMS my second year in residency, and that was a long time ago. I had hair back then, and I have not missed an ECTRIMS since then, and I never plan to. ECTRIMS is literally the Olympics of MS with, I'm talking over 10,000 MS specialists all getting together once a year and sharing the absolute latest and greatest information, the bleeding cutting edge of research, what's new and what's coming and where we are with the field. It's also an awesome opportunity for me to meet up with my international MS friends from around the globe to talk to them and to compare notes. And so I think it's really cool that your PA met me. So please say hello, howdy, hi to them. All right. So what else do we have going on here? Do I need a lumbar puncture even if I do an MRI? That's a great question. Do I need a lumbar? Well, so there's different times when you would get a lumbar puncture as it relates to MS. So when you're making an MS diagnosis, you have to take a history. You have to ask the human being a bunch of questions. And you have to do a neurological examination. You got to do a full neuro exam. And you have to get MRIs. You're going to get an MRI of your brain and cervical cord. And in my opinion, oftentimes that provides enough information to make a diagnosis. If there's an atypical situation, sometimes a lumbar puncture is beneficial. And I would suggest that where I work, we probably get an LP less than 10% of the time. We do not routinely get lumbar punctures because we find that we don't need them. Now, there are situations diagnostically when a lumbar puncture could make the diagnosis. And so there are situations where you are going to be asked to have an LP. But there's a lot of times where I feel it's not necessary. Now, once you have the diagnosis, why would you get a lumbar puncture? And generally speaking, it's not necessary. There are situations where you're testing for infections, and so you need to look at the spinal fluid to look for infections, but that's kind of a different situation. So I'm assuming that the person writing the question, VAHRA, Varha, I hope I said that right. Varha is asking the question. I'm assuming they're talking about diagnosis. And if that's correct in my assumption, you got to have an exam, you got to have MRIs. And if that's adequate to make the diagnosis, I don't think you need a lumbar puncture. If it's not adequate, you're either going to be repeating MRIs down the line and or maybe getting a lumbar puncture to clarify the diagnosis. Now, if you'd like to hear more about this, I have videos on how do you diagnose MS. I think I put that out within the last month. And so you can look at my channel and you can find that video, which talks about this in some length. So Andrea W. writes in, do we still get more lesions as we age? I'm 53. Well, hello, Andrea. Nice to meet you. And the answer is yes. So MS doesn't stop. It doesn't go on vacation. It doesn't take a smoke break. It doesn't sleep at night. The immune system is constantly surveying your body and your brain, looking for bad guys. It's looking for bacteria and fungus and parasites and viruses. And when it sees bad guys, it beats them up. In the setting of autoimmunity, your immune system made an error in judgment, and it thinks that part of your body is a foreign invader. In the setting of MS, that's the supercomputer that runs the body, the brain, and the spinal cord. And so when your immune system does its tour of duty and it sees that part of your body, the brain, it can attack it. And that can manifest as a clinical attack, or that can manifest as an MRI spot without an attack. Now, as you age, you're less likely to get spots. Statistically, you get more spots when you're younger as compared to older. And so a 20-something is going to have a lot more new spots than a 60-something. But that doesn't mean that the 60-something isn't having new lesions, because you can. And so I think that it's relevant to continue to get an MRI in someone annually when they're on an MS drug. Now, I recently shared that after the age of 60, I start to be more lenient, so to speak, and I don't recommend that you need it every single year. I think after the age of 60, you can discuss maybe stretching it out to every other year. Now, that's a very individualized thing. And I have some patients that are over 60, and we have made a shared decision to continue to get a scan every year. But I have other patients where we have made a shared decision to start to space them out every other year. Why? Because as you age, your immune system slows down a little bit. And so it stands to reason that you don't have as many spots and that you're less likely to pick stuff up. And so that's why I start to spread it out. Now, that's my opinion. It doesn't make me right. And it doesn't mean that everybody should do that. I'm just sharing with you what I like to do in clinic and why. And maybe this is food for thought for people to discuss with their own MS doctors. All right, next question. Melanie writes in, Dr. Boster, does a foggy feeling come from damage to the cerebral cortex? So Melanie's talking about cog fog. Cog fog is a symptom where you're just not firing well. You're just kind of a little bit foggy and confused, and you can't think as sharply as you once did. Cog fog is really common in MS. I have several videos dedicated to cognitive fatigue and cognitive impairment in MS. And to talk a little bit about it now, I think that the reason that people have cog fog is not from cerebrocortical lesions, it's from something else. And I'll explain it to you. When you have an MS lesion, it damages the brain. Remember, that's brain damage. And what your brain does is it rewires. And so imagine that here's a lesion, and the brain is trying to send a message through it, and it can't. So what the brain does is it literally just goes around it. The same way that when you're driving and you see a big pothole, you just go around it, right? But that takes more effort. And over time, as you have new MRI spots, as you develop more brain damage, your brain has to keep rewiring. And what ends up happening is that in order to get the job done, you have to use a lot more brain. Now, this has been very well studied, and I'm going to use a specific example. There's a study that was done looking at people wiggling their finger when they're in an MRI, but it wasn't a normal MRI. It was a functional MRI. So when they wiggle their finger, we could see which parts of their brain were involved. And in a healthy control, when they wiggle their finger, just the motor cortex, a very small amount of brain right here, lights up, and that controls finger wiggling. When they put someone with MS in the scanner and they wiggle their finger, they had both hemispheres light up like a Christmas tree. Quite literally, the human with MS was using a tremendous amount of brain, not just this, and this, just to wiggle their finger. Now, the key here is they wiggled their finger just as well as the other guy. It's not like they couldn't wiggle it or that they did it poorly, but they needed a lot more brain to get it done. And I think that's where cog fog comes from. It's because you're expending boatloads of energy. I mean, really, really working really hard to try to get the job done. If I use a physical example, imagine that you're going to go on a promenade, all right? You're going to go on a stroll, and you're going to walk with your friend. Except we're going to strap weights to your boots. We're going to add 25 pounds to your left foot and 25 pounds to your right foot. And you say, okay, go walk. Now you're going to try to keep up with your friend. And your friend's taking light steps and walking, and it's not a big deal. And you are really huffing and puffing and trying to move your leg forward. And you might be able to keep up with them. But you are going to use a lot more energy and a lot more muscles to get the job done. That's what's happening cognitively when people are trying to think. And I think that's where cog fog comes from. Now, knowing that, there's a couple things that you can do. People tend to fare better thinking and memory when they've had sleep. And so making sure that your sleep is quality is really, really, really important. It's super, super important. And if you're not getting good quality sleep, if you're not getting enough sleep, that is bad news bears. And you can use the power of the nap. Naps are your secret weapon. I take care of a lot of people that have cognitive related jobs where they really need to think in order to do their work. And some of them find they need to plan big meetings first thing in the morning when they have the most energy, or they take a power nap for an hour in the middle of the day, and then they're revitalized. Now, there's a lot of other things you can do to improve cog fog, and I've got a lot of videos on that, and I would like you to check them out. Things like embracing exercise. There's even medicines that can help with cog fog, stimulant medicines that can be very helpful. But I hope that answers your question. And Melanie, thank you for asking it. There are 146 people online. That is really cool. Now, remember, guys, why are we doing this right now? We're doing this because we're a community. We're a village. We're a virtual village, and it's a global village. And we are helping raise awareness. It's MS Awareness Month, and it's our goal to empower, to educate, and to energize people impacted by MS. And I am loving this community, and I am loving that you guys are online with me. Thank you, thank you, mwah, thank you. If you're digging what we're doing, let's get another thumbs up. Click that thumbs up button at the bottom of the screen. All right, on to the next question. All right, let's try this one out. Keith writes in. Keith from Michigan. We need a video that would be used to inform our friends and family about MS. Less detail, but more on what we experience. So, Keith, I think that's a great idea. I do have some videos where I talk about newly diagnosed MS. Actually, if you look at the channel, the intro, when you pull up the channel page, the highlighted video is a message to newly diagnosed patients. And I do speak about that a little bit. But I love your idea. I'm going to write it down, and I'm going to give some serious thought to how we can come up with how do you talk to friends and family. I think that's an excellent video topic, and so you can look forward to that once I work out the details, and I'll record that video. Thank you for the idea. So I've got Amelia online. She says, fatigue. I'm currently taking amantadine for MS fatigue and have been so for about 5 weeks, she writes. I don't feel any different yet. Would you recommend staying on them, or would you try something different by now? Now, Amelia, as you know, I can't answer you specifically because I haven't examined you. I haven't taken your history. I haven't looked at your chart. I don't know what other medicines you're on. So I can't give you an answer, but I can speak generally about amantadine, and I can talk about medicines. So please understand that I can't answer you, but I want to at least provide some education. Amantadine was invented to treat viruses, and it's been used a little bit in Parkinson's disease. It turns out that taking amantadine twice a day helps some people with MS have more energy, which is really cool. In my experience, a lot of patients don't respond to amantadine. Some do. And so I think that trying amantadine, if you have energy problems, is a decent idea. How long should you try it? Now, that's something to discuss with your MS provider. I'll share with you, generally speaking, we have someone try it for about a month-ish. And at the end of the month, if they haven't noticed a benefit, we may ask them to stop it and then to pay close attention. The reason I bring that up is sometimes you don't realize that it's helping. And when you stop the medicine, then you're really fatigued and you realize it was working. And if it's not working, there's a bunch of other medicines that one can try. And so I think that the punchline here is you need to reach out to your MS provider and say, hey, it's been 5 weeks. I'm not feeling any different. How much longer do you think I should do this? Or should I come back in and have a conversation with you about something else? All right, what else do we have going on? Natalie writes from Los Angeles. Hello, Natalie from Los Angeles. What are your thoughts on hepatic stem cell transplants? So that is a great question. It's a very hot topic. I shared with you guys that last week, we at Ohio Health had a giant CME program with over 210 providers. And one of the excellent lectures from one of my colleagues was on stem cell transplantation. I'm working to try to get a hold of those lectures so I can publish them on my YouTube channel. And so I hope that I can bring you a really awesome lecture on stem cells. Now, it's a very high level lecture, but you guys can handle it. And I'm going to try to get a hold of it and put it on this channel. To answer your questions, I think stem cell transplantation is something that we should be researching. I think stem cell transplantation is a very promising research therapy. I do not believe that stem cell transplantation is ready for prime time. And there are some really, really good clinical trials going on around the world. I have a friend up in Norway who's doing an amazing stem cell transplant study comparing stem cell transplant against Lemtrada. Very provocative work. There are really good registries in Canada. A friend of mine, Mark Friedman, has done some amazing work looking at stem cell transplantation. When I was at the university, I participated as a sub-investigator in a trial called the HOLT trial, where we gave stem cell transplantations to 4 of our own patients. But I do not think that stem cell transplantation is ready for prime time. Right now, there are places, exotic places you can travel, stem cell transplant tourism, where you go to an exotic place like India or Mexico or Chicago, and you pay them $25,000 and they give you a stem cell transplant. There are major, major concerns with that. There are major concerns that some people may be swindled. There are major concerns about safety, and there are major concerns about long-term follow-up. And so I do not think that you should participate in stem cell transplantation tourism. In fact, the FDA is cracking down on some of these quackeries where they're providing false hope and putting people at risk. But I do think that stem cells are something that should be studied in research. And it's my prediction that stem cells in about 5 to 10 years may become part of the MS armamentarium. So stay tuned. Really good question. It's been 40 minutes. There's 146 people online. I have 82 thumbs up. I'm kind of hopeful that I can get 100 thumbs up. And so if you haven't clicked that like button at the bottom of the screen, please click that like button. I've got a question here from Born Again Farm Girl, who writes, MS came to me at age 18. I'm diagnosed since 2008. Could you share with others about itching in MS? I'm still mobile, but crazy dizzy. Tracy in Illinois. So there's a lot of info in that question, and I'm going to highlight itching. So I did a video on pathologic itching, and if I remember, I'll try to throw a link down in the description below when I do the post later on. But in a nutshell, itching is a type of pain. And in fact, the areas of the brain and spinal cord that light up when you have neuropathic pain are the same parts of the brain and spinal cord that light up when you have pathologic itching. Now, I'm not talking about I have a little itch. I'm talking about an unrelenting, terrible, deep itch that doesn't go away. And it can be super detrimental to people's quality of life. I have heard patients tell me that they were told MS doesn't cause itching, and that's false. MS does cause itching. It can cause pathologic itching. It's an unusual and absolutely horrible symptom. And it's also a hard symptom to treat. Now, there's a lot of different medicines that we use, and typically we're using neuropathic pain medicines. We're using membrane stabilizers like antidepressant medicines and anti-seizure medicines, trying to quell the itch. Sometimes we're very good at it, and I have had a couple cases where I wasn't able to control it, but it is a symptom of MS. And if you're having pathologic itching, think about it like another form of pain. Tell your MS provider about it and ask for symptomatic improvement, ask for symptomatic relief, because I think that's a terrible thing to have to live with. Karen Tweed writes, your clinic staff and patients have been generous to volunteer and participate in your channel. If you want to monetize and find further education for your clinic staff, I say go for it. Karen, that's fantastic feedback. I'm really excited. And remember, guys, I'm asking you to write into the comments and tell me what you think about the channel. Because I recently was eligible for monetization and I clicked the yes button and now I'm monetized and I don't think I like it. I'm not sure how I feel about it. And so I'm asking you guys to please share with me your thoughts. Do I A, turn the monetization off, or do I B, keep the ads going and use the money in a foundation fund to help educate people in my clinic, specifically our employees, our nurses, social workers, nurse practitioners, physical therapists, etc. So please leave your comments like Karen did down below. I'm really eager to read it and tally them up later. All right. Tara writes in, can you explain optic neuritis and the long-term effects of optic nerve damage? So that's a great question. MS affects the brain and spinal cord. And part of the brain includes the optic nerves. So going from your brain, you have a nerve that's attached to your eyeball, and it provides all the functionality to your eyeball. Think of it as like a really big wire that goes from your brain to your eyeball. That's called the optic nerve. And so you have one over here and one over here. And optic neuritis, itis means inflammation. Optic neuritis is inflammation of the optic nerve. And so typically what happens is that someone will notice pain with extraocular movements, meaning when they look left and they look right and they look up and they look down, it hurts their eye. And the reason is the nerve behind the eye is swollen. And so when you move the eye, you're kind of stretching the nerve and it really hurts. They will also notice change in their vision. So their vision in that eye can be diminished. They can have a slow loss of vision. Sometimes they can have tunnel-like vision. They can become grayed out, and it can go to the point where they actually go blind. And those are the two most common presentations associated with optic neuritis. Now, on physical exam, we can see the damage sometimes by doing a flashlight test called the swing test. And the lights have to be pitch black. The provider has to turn the lights off, and then they shine a light in this eye, and they watch what the pupil does. And then they shine a light in this eye, and they watch what the pupil does. And they go back and forth. Now, I have a whole video series on decoding the neuro exam, and I show the swing flashlight test in one of those videos. And so if you'd like to see me performing the swing flashlight test on actually on Amber, my MA, then you can check out that video. Optic neuritis is an attack, and it's not uncommon in MS. And it can lead to permanent damage of the vision. And obviously, we want to provide therapy to try to hasten the recovery and maintain vision as much as possible. And so the way that we do that is we give high-dose steroids. We typically give IV Solumedrol or very high-dose oral steroids for 5 days in a row. And the goal is to quell the inflammation of the optic nerve and save the vision. And it can slowly come back. You can see improvements up to 6 months, I feel, after you treat the optic nerve. There's one really fascinating trial, just one little trial, where they looked at giving the optic neuritis treatment with steroids, and they added an old seizure medicine called Dilantin. And surprisingly, adding Dilantin seemed to make the optic neuritis better. The people fared better. And so on a couple of occasions when we've had optic neuritis in the clinic, we've added Dilantin to the Solumedrol. The goal is to preserve the reserve and to preserve the nerve. And thank you for asking the question. All right, guys, it's 47 minutes. I got 141 people online. We've had 116 likes. I am loving that. Thank you. Thank you, guys. That's really, really awesome. I'm a little bit overwhelmed. And let's take a couple more questions before I have to go to a dinner meeting. So let's see what we've got here. Jamie writes in, is Gilenya a decent first-line treatment? Have you heard much about monomethyl fumarate? I didn't tolerate Tecfidera, and I have fatigue and migraines. All right, so that's a bunch of questions. I love those questions, and I'm going to answer them. So for starters, Jamie, thank you for writing in. The first question is Gilenya a good first-line treatment? And the answer is yes. Gilenya is a great first-line treatment. I think Gilenya is a moderately effective drug. It's not the most effective drug, but it's up there. It's probably in the top 4 in my opinion. And Gilenya is a once-a-day pill. It's very well tolerated. Now, getting on Gilenya requires jumping through a couple hoops. Once you're on Gilenya, it's a pretty easy drug to take. You're taking a pill once a day. You're checking your liver enzymes every 3 to 6 months. In the first year, you're going to check out your vision with a special test once or twice. And basically, you're taking a pill once a day. And so for a lot of people, that is an awesome lifestyle, where they're not having to give themselves shots and they can travel anywhere they want and they just need their pills with them. I don't think Gilenya is the most effective medicine. I think it's way more effective than the shots, way more effective than the shots. I also think that it's probably more effective than the other pills. That's my opinion. And so I do think that it's a good choice. And so I hope that answers your question. Now, the second question was about monomethyl fumarate. Now, Tecfidera, the branded medication Tecfidera, is dimethyl fumarate. And when you swallow Tecfidera, it's metabolized and turns into monomethyl fumarate. And I recently saw a really cool trial put out where they were studying this monomethyl fumarate. They're studying a different version. And I don't have any clinical experience using it. I don't know how you would fare if you had trouble on dimethyl fumarate, Tecfidera, and switched. But when I read the top-line data for the trial, it looked like it was better tolerated. So that's very interesting. I don't have any clinical experience, so I can't comment beyond that. Let's see what else we have. So True Tech writes, the Lemtrada seems like somewhat of a cure, and it's not a cure, but I want to talk about that. And so thank you for bringing that up. We in 2019 cannot cure MS. I wish we could, but we can't. A stem cell transplant is not a cure, and Lemtrada is not a cure. But I want to flirt with a very special word, remission. I have a video on remission, and if you haven't seen it, I want you to go check it out, please. But I use the following definition for remission. If you have no discernible disease activity for 5 years and you are not on a therapy, that's remission. And so there are some patients that have taken the Lemtrada that have made it out past 5 years. They're not on a therapy and they have no discernible disease activity. And I think in that situation, we could say they're in remission. Now, if you look up the word remission in the dictionary, it doesn't say cure. It says what I just said. And it is possible that disease could reemerge. I would like us to embrace the definition of remission as 5 years with no discernible disease activity, not on a therapy. And so I think it is possible for some people that they have remission in the setting of Lemtrada, but it is not a cure. Excellent question. All right, guys. Ted Michael writes in, hey, Dr. B. Well, hello, Ted. I've been on Ocrevus for a year now. Because the insurance and my neurologist retiring, I'm a week late for my Ocrevus infusion. How long can I go before it's an issue? Well, Ted, I want to reassure you that I don't think that's a big deal, personally. We say every 6 months, but I don't think 6 months is gospel from up on high. And I have a lot of patients where they're going on a cruise the week they should be infused, or they get an infection, and we just wait till the following week. And it's not a big deal. Now, I don't think you should wait months. I think that might be a problem. But if you're a week or two late, I don't sweat that. I really don't. So let's look for some more questions. Whoops, something weird happened. All right. I am not good at reading these questions, guys. I apologize to you. I just lost my place in line. I'm not sure, so I probably missed some people's questions. You know I'm going to try to pick them up in the post, but let's jump into this one. Donna Jones writes in. So hello, Donna. She says, hello from Marion, Ohio. So it's nice to see you. My daughter has chosen Ocrevus for her treatment. Will this medication help her with her symptoms, or is it to stop the development of new activity, or both? That's a great question, Donna. That's a really good question. First of all, I want to say thank you for caring about your daughter. I want to say thank you for jumping online and learning about your daughter's condition so that you can be the best village member possible. Remember, guys, this is MS Awareness Month, and I think that we need to give a shout out to Donna Jones for caring and loving her daughter and wanting to educate herself. So, Donna, thank you. Now, on to your question. The goal of all disease-modifying therapies is they're like a birth control pill against future activity. So I like to joke, if you have 3 children and you start taking birth control, you still have 3 children. And my joke is, if you want to know why you're taking birth control, go hang out with your children. I'm just teasing. But my point here is, you don't take birth control to get rid of your kids. That's already happened. You take a birth control pill to prevent a future unplanned event, a pregnancy. In a very similar way, we take MS disease-modifying therapies not to undo brain damage that's already occurred, because we can't really do that very well. It's to prevent future brain damage. So really, the first part of your question is that we're using Ocrevus or some other disease-modifying therapy to help prevent future attacks and new MRI spots. That being said, some of the drugs do more than that, and Ocrevus does do more than that. We know that Ocrevus slows disability progression. It slowed disability progression by about 40% better than Rebif, which slows progression about 30% better than placebo. And so that is in addition or separate to, it would appear, than just the relapses. We also know it maintains hand function in people that are in wheelchairs. We know that it slows brain shrinkage. We also know that it increases the likelihood of confirmed disability improvement. For example, compared to Rebif, we saw a 33% higher likelihood of confirmed disability improvement for people that were taking Ocrevus. So the party line is we're trying to prevent future events, but it is possible but not common, that you can see improvements to disability function. And you certainly can slow down disability and brain volume loss. Very awesome question. Thank you. Sarah Woods writes in, if you're on your phone, click the X. Oh, so she's explained to us how you do the live chat. Sarah, thank you for that, because I'm not very savvy about this kind of stuff. I appreciate that. I'm not going to read the comment, but I appreciate you helping out. All right. What do we got going on here? Dara, my buddy from Great Britain. Hello, how are you, my friend? He writes in, thank you. My MS provider told me that MS does not cause itching. So he's wrong. Your MS provider is not accurate. It does cause itching. In fact, Dara, you can look in PubMed and you can find articles talking about MS and itching. So it's been documented in the medical literature. He also writes, can hearing also be affected? Yes, hearing can be affected. It's not very common, but it can happen. Sometimes people get tinnitus where they have a ringing in their ears, and sometimes they can't hear out of their ear. It can happen because obviously the sounds coming into your ears have to be processed by the brain. And so if there's damage to those structures, you can lose hearing. It does happen. Not common, but it is true. All right, guys, we're getting close to the end of the hour. I'm going to start to wrap up. Let me take one or two more questions. So Jamie writes in, totally just reminded that I haven't had enough caffeine yet today. That's awesome. I am a fan of coffee, as many of you know. When I'm in clinic, it's my pleasure and joy to have a cup of coffee with almost all of my patients. Certainly every single one of my patients in the morning, and in the afternoon, I might have a cup every other patient. But I really do enjoy my coffee very, very much. And so if you haven't had your caffeine, you got to go get it. All right, let's see here. Last question of the day. Damien 6 Robin. I love these guys. This is a fantastic couple. And they write in, I'm on Ampyra and Baclofen, and more than twice. I have been close to stopping them, but I know that it's more likely bad news for my MS in the end, so I still take them. So let's talk about that. They're taking Ampyra, which is a 4-aminopyridine. That's a medicine to help with motor fatigue and heat sensitivity. And they're taking Baclofen, which is a medicine to help with spasticity. And these are what I classify as symptomatic medicines. Ampyra and Baclofen don't slow multiple sclerosis. They don't decrease attacks. They don't slow disability. They don't stop spots on the MRI. What do? They treat symptoms and they improve quality of life. And that is really, really important. Now, if you don't take Baclofen and if you don't take Ampyra, your MS doesn't go faster and it doesn't go slower. And so we don't take Ampyra and Baclofen for that reason. We take them because you have horrible spasticity and that stinks, and you want to improve the quality of your life and you want to be more functional. Or you take Ampyra because you start walking and you get exhausted, your legs stop working, or you get overheated and you can't function. And so you're treating symptoms. I'm of the opinion that if we slow your disease down with disease-modifying therapy and you're miserable because of a poor quality of life, we didn't do the best job we could. In order to feel proud, in order to go home and look at my children and say, today, Daddy did a good job, I feel like I have to do two things. I have to slow the MS progression, I have to slow down the disease, and I have to improve the quality of your life. And one of the major ways that I try to improve your quality of life is by treating symptoms that bother you. So if you have spasticity, I'm going to talk to you about treatments for spasticity. Now, you can choose not to do them, but I'm going to talk to you about them in case we can find one that fits with you. And that was a great question, and thank you for asking it. All right, guys, we are about at the top of the hour. I've been online now for almost an hour with you guys. I have had a wonderful conversation, and I want to say thank you. I specifically want to say thank you to Charles and Karen, my dad and stepmom, for jumping online. You guys are wonderful, and I really appreciate it. I want to remind all of you that it's MS Awareness Month, and so we have an obligation to raise the level of awareness. We want to educate, we want to empower, and we want to energize people impacted by MS. And that's what we're trying to do here on this channel. And you have helped me do that today. I also really appreciate you guys weighing in on my quandary, on my big question about my channel. I recently achieved monetization, and I'm not sure how I feel about it. And so I'm trying to decide, do I A, turn off the monetization because it's not really my goal to try to make money on YouTube? Or do I leave it on and use that money to help fund my my funds that I use to train and educate my staff? And so the team members that I get to work with, do I use the money from YouTube to help send them to conferences and educate them? And so please leave your comments down below. It means a lot to me. My name's Aaron Boster, and thank you very much for learning about MS with me. Thank you for caring, and thank you for supporting me in this channel, and thank you for supporting each other. And until my next live stream or my next video, take care.